full disclosure, didn't actually have a chance to do a run through of this. So if this is painful, I apologize. Hopefully not. All right, so this is a little bit of an experiment, this sort of lecture series we're trying. So this may be too basic. It may not be basic enough. So let me know at the end how you feel about the general vibe. Trying to find a sweet spot, but you never know. All right, so we're talking about hypertension, specifically how we encounter it in the hospital. So this is just a brief roadmap of what we'll be going over. Talk about diagnosis and definitions, management, complications, and then a little brief conclusion. So for diagnosis and definitions, of course, diagnosis we'll talk about. Also definitions of resistant hypertension and then primary versus secondary. So diagnosis. Best done outpatient. It's ideally not diagnosed in the hospital. Usually done over several visits. Often they do ambulatory home blood pressure monitoring. Sometimes during the daytime, sometimes at nighttime. You can actually get different thresholds for diagnosis if you do nighttime monitoring versus daytime. None of that is anything we would ever be doing here. So for our purposes, they will either have a pre-existing diagnosis or they will not. If we want to diagnose them in the hospital, generally the only accepted definition for one episode hypertension is if it's over 200 systolic. Some would argue over 180, questionable. So there's no perfect way to do it inpatient. For outpatient, the definitions are for stage 1, if it's between 130 and 139 systolic or 80 to 89 diastolic, doesn't matter which one, can be either or, can be both. Caveat is that the European guidelines actually just exclude this altogether. They don't start till 140. American guidelines used to not start till 140. This was like pre-hypertension in the 130, but current American guidelines start at 130. And then stage 2 is anything above 140 or above 90. Again, either or both. So resistant hypertension is not the same as poorly controlled hypertension, which I often see written. It's because there's a very explicit definition for resistant hypertension, and that is that you're poorly controlled on these specific things. You have to be on a max dose of at least 3 different antihypertensives, and one of them has to be a thiazide. If they're not on 3, including a thiazide, they're not technically resistant. You just haven't tried enough yet. If they're on 3 and if they're on all of these things and they're still hypertensive, then they are resistant, or they're not taking it. Hard to know for sure. But that is the formal definition of resistant.
Can we ask questions?
Absolutely. I love questions.
Is there like a time limit for the drink? Like, does it have to be 72 hours?
I don't think there's at least I didn't come across a formal time limit. I would say it's whatever time you would expect any of, like, if you added your 3rd medicine or maxed out your 3rd medicine, if at the point at which you would normally expect that medicine to have taken effect, they're still high, then you would consider it. But I don't think there's a definitive date.
Why a thiazide?
Thiazides are the best for pressure of the diuretic class. And I don't know the exact reasoning behind the original definition of this. My guess would be that historically, people have thought that, especially in African-American communities, that not having a diuretic of some kind would predispose them to worse hypertension, that they really needed that as kind of their first line. It's debatable whether or not that's exactly true, but I suspect that's probably part of it. But I don't know the exact reason for other, like thiazide specifically, because it's the best of the diuretics for pressure, but why a diuretic at all, not exactly sure. All right, and then briefly for the definition of primary versus secondary, your primary is also called essential. That's what we typically treat. There's no underlying cause. They just have hypertension. Mostly people with multiple other risk factors such as obesity, heart disease, diabetes, etc. And then sometimes just genetics. Honestly, a lot of times just genetics. Secondary hypertension is hypertension arising from an underlying cause. And I wanted to talk about secondary hypertension briefly because it bothers me. This and hypertensive emergency are 2 of my little pet peeves. So when should you consider secondary hypertension? Because I don't think we're considering it enough. So any patient with a systolic over 200, you really should never get over 200 with normal primary hypertension without Perhaps if you're in extreme pain, or you've just had a trauma, something like that, those are kind of the exceptions. Otherwise, if you're just coming in off the street, you feel fine, you shouldn't be over 200. Something's probably going on. Actually, I don't think I put resistant on here. You should include resistant as times to consider secondary. And then any patient who's admitted for hypertensive emergency, because again, you shouldn't get that hypertensive that you have caused end organ damage from primary. Not that you can't, but it's atypical. This is a brief review of secondary hypertension causes. Medications are a big one that I think we often overlook. Birth control for women of childbearing age, NSAIDs. People are using a lot of NSAIDs. If we're giving NSAIDs, it's not a huge increase from NSAIDs, but it's a noticeable one. Antidepressants, of these, the TCAs and SSRIs are the ones we use the most. MAOIs, I can't remember the last time I saw somebody on an MAOI, but theoretically, steroids, something we often give here. Decongestants, don't give them as much here, but often people are taking them at home. The older weight loss meds like phentermine, Fenton, don't see a lot of those anymore. Tacro and cyclosporin, I didn't realize those two actually, that was new information to me. And then obviously if you're on ADHD meds, amphetamines. And then the illicit versions of amphetamines, your cocaine, meth. And then outside of things you're taking in, chronic kidney disease. And then a lot of these are endocrine problems. So hyperaldo, you have the primary where it's Conn syndrome, where it's just the adrenal gland has malfunctioned, or you can have secondary, which is most commonly, I find a consequence of diabetes. It can actually be a consequence of hypertension itself too. And then renovascular hypertension, which includes renal artery stenosis or the dysplasia, obstructive sleep apnea, also extremely common in our patient population. Any thyroid problem, thyroid just does whatever it wants. It's on my list of things I believe absolutely anything you told me about. Hyperparathyroidism, coarctation of the aorta, much less common in adults, usually caught in children if it's bad enough to cause differential blood pressures, but theoretically. Cushing's disease, and then a FEO. I put FEO last because it's the least common, but it does happen. Somebody has to be the zebra. All right, so, and actually, just to say one more thing about this. So you should consider secondary hypertension in your patients who have those really high pressures or hypertensive emergency or resistant hypertension. I usually consider all of these things just sort of intellectually, like you're not going to do a workup for every single one of these. You're just sort of going to screen in your head, do they look Cushingoid? Is that a possibility? Or obviously medication review. Do they have any reason I should think they have a thyroid problem? Things like that. And so if you don't have any of those things, then you don't have to necessarily go looking for something specific. But if you can sort of intellectually screen them and find something obvious, then I would go looking for that specific thing.
And if you intellectually screen them, is there ever a time where you're like, that doesn't make sense, that doesn't make sense, but like, I should definitely check X, Y, and Z because of like how common this can happen or like what's overlooked?
So the most overlooked one, I would say, is probably hyperaldosteronism. And unfortunately, it's also one of the hardest to diagnose. As you have to be sort of in the perfect setting. I think it has to be an 8 a.m. sample of renin and aldo seated. I think they have to be seated for 30 minutes before you draw it too. So it's a very specific way of getting the lab. Similar for FEO, you have to not only have them quiet, seated, actually, I think they have to be supine. You have to put the IV in to draw blood an hour before you draw the blood because just sticking them can cause spikes of adrenaline and noradrenaline. So it's very hard to properly diagnose these things. Which doesn't mean we shouldn't try, but it's really an outpatient workup for those. So the only one of these that I would actively do something for, thyroid's maybe one, if you think it's plausible, we test enough people for thyroid, there's enough reasons to do it, you can justify it and it's cheap. But for hyperaldo, if I really suspect it, I honestly just usually put people on spironolactone if they can tolerate it, because that's the treatment of choice anyway. You can't formally diagnose it while they're taking spironolactone, that's the downside. But if it makes their pressure better, that's the only thing you would do for it anyway. So it doesn't, then it's really just an intellectual activity to diagnose it formally, because you don't, if they're getting better on the medicine, that's all you would do anyway. So that's my personal practice. All right, so then management. We're gonna talk about how to choose an antihypertensive, what to do inpatient specifically, and then how to manage discharge meds. So how to choose a med, part one. So in general, these are your three first-line agents. You got ACEs or ARBs. ARNIs have not been included in this. I think primarily because their indication, or at least their FDA approval, is for heart failure specifically. There may be a time when they're added in there, but currently just ACEs and ARBs. Then calcium channel blockers, usually we do amlodipine, and thiazides. So my practice is I first consider what comorbidities does this patient have? Do I have a compelling reason to use one over the other? Because there is no guideline for choosing one over the other. It's kind of whatever feels right if they don't have a compelling reason to do another one. So do they have diabetes? Do they have kidney disease? Do they have vascular heart disease? And so then you talk specifically about those things. So if it's a diabetic patient, technically only if they have albuminuria is it an indication to specifically use ACEs or ARBs. Unofficially, we've all been doing it anyway, and it's one of the first line choices anyway. So if you don't have a compelling reason to do something else, I don't see any reason why you would still choose this.
So for the HR, so like when we're looking, so I was talking, I have a few things, it's like, it's like the urine is like gradient reflux, they would benefit from an HR. So like I had somebody tell me one time, like I can't go off of it's reflux urine, I actually have to do a whole.
So formally, technically, you should be quantifying the albumin. Informally, if you think they probably have real albuminuria and you don't have a reason you shouldn't do an ACE or ARB, you don't have a good reason to do something else, I think that's good enough. Just in the interest of stewardship of our resources, I don't see reason you have to quantify it. Some of these things are just more intellectual than anything else. Like it's nice to know, but if I don't have a reason I can't give it to them, I'm just gonna give it to them. And then heart disease, so you have your ACEs, ARBs, or ARNIs in this case, a beta blocker and aldosterone antagonist. The aldo really more for CHF, not for MI per se. The beta blockers specifically, if you're using it for hypertension as well as for heart failure, you really want to choose carvedilol. You're gonna get a lot better bang for your buck, hypertension wise. Which overall is just like a little sprinkling. So not saying you can't use metoprolol, it's just not going to give you as much effect. And then the aldo antagonist is usually for the more severe levels of heart failure. So not usually your stage 1 or your heart association class 1. Usually starts at 2. Then AFib, you might want to do a beta blocker. It's the only time beta blocker is ever considered potentially first line. And then, so this is harkening back to the thiazide thing I mentioned earlier. Previously, there was a thought that Black patients benefited more from thiazides or calcium channel blockers over ACEs and ARBs because there was significant difference between white patients versus Black patients for how they responded to those. But since then, there's been more data that's come out that shows that the inner variability just among Black patients. Why'd y'all lock her out? So mean. But so there's been evidence that shows that the variability just between Black patients is actually more than the variability of Black versus white. So essentially, there are plenty of Black patients who would benefit from an ACE and ARB, and there's no real way to tell who that's going to be. So the new thought is that there's no reason to pick any of these three over the other based on race alone. And then for our patients who have no comorbidities, really you just want to look at your side effect profiles, what that person might want or not want to tolerate. So for amlodipine specifically, you're going to get peripheral edema that might bother some patients. A person who already has venous stasis, probably not going to be your first choice for that patient. Diuretics, you've got a really elderly or frail patient or somebody who can't get up and move easily, or somebody who's already got a lot of wounds and you don't want them to be sitting in urine more often. You might want to not choose a diuretic. Also somebody who's really prone to dehydration. And then ACEs and ARBs have the risk of angioedema or cough. ARBs obviously don't have as much cough risk. And I mean, if they have angioedema, it's just a contraindication flat out. It's just unfortunate, but. All right, and then a couple other thoughts of beta blockers. So you only use it as a primary or first line in the patients who have a comorbidity that requires it, so heart failure, AFib. Beyond that, you really shouldn't use it. You should never use it as monotherapy, except in those cases. And outside of those cases, it's rarely used as a blood pressure. Like if somebody doesn't have those two problems, it's better to max them out on the 3 first line, and beta blockers should be your 4th, 5th, etc. And then you shouldn't use it in patients with bradycardia or borderline low heart rates. I didn't finish this slide. I'm just realizing I was supposed to have another bullet point there. I'll just say it. So your second line agents, you've got mineralocorticoid antagonists, like aldactone or spironolactone, or eplerenone, which doesn't get used a whole lot, but it's still around. I think they're criminally underused because I think we are undertreating hyperaldo. They did a study on resistant hypertension several years ago and found that of the ones that could have, like, where they found a secondary hypertension diagnosis, it was like 40% of them were hyperaldo. So we should be using more aldactone. That's my summary there.
You ever look at the baseline potassium and kind of factor that in?
That's a good thought too, and probably should put it on the previous slide. If they have high potassium, probably don't want to use that as your first line agent or an ACE or ARB2. Yeah. And then I've intended to add things like clonidine and hydrol and such on here. I forgot to. Clonidine, I never use it. It's my absolute last ditch. I will sometimes slap it on somebody, like a patch on somebody who can't take an EPO, and like an end of dementia type patient where it's really bothering the family that their pressures are high, but you just feel like you're compelled to do something about it, even if it doesn't really matter long term. That's really the only time I use it. Or just the patients where they're on 5 meds already and I'm desperate. It's really the only time I'll use clonidine. All right, so then I have a little case here, and I labeled it case number 1, but I never came up with a case number 2, so it's really just case. So our fictional patient here, Mr. W, has a past medical history of hypertension, diabetes, former CVA, no residual effects, came in with a diabetic foot ulcer 2 days ago, had a debridement, he's feeling well. Nurse pages you that his afternoon BP is 192/100. He has no headache, vision changes, chest pain, or any other acute complaints. So what do? You've got IV labetalol, IV hydrol, oral clonidine, or you can restart his home and load feed.
Is there more than one answer?
There's only one answer. At least I only have one answer. That is correct. So we'll go over a couple of things and then we'll explain why that is the correct answer. So first of all, we have to find out if you get a pressure like that, is that even a real reading? Did they repeat it? Did they only do it on one arm? Check both arms. Have they done a manual? Has the pressure been running high and this is a sudden, or is this a sudden change? Did they use the right cuff size? If you have too small a cuff, you're gonna get too high pressure. If you have too large a cuff, you're gonna get too low a pressure. So I always check that because often they're using the wrong ones. And then was the patient at rest? Did PT just walk out of the room and the PCT walked in and checked their blood pressure? Same with heart rate sometimes too. So assuming it is real, assuming you've repeated all those things, verified all those things, then who needs treatment? So anyone who has symptoms, of course, they've got a headache, if they have vision changes, chest pain, any of those things, you do want to treat those patients. But if they're asymptomatic, studies have shown that adding any new antihypertensives in the hospital outside of their home meds results in worse outcomes. And the number needed to harm is only 56. But we see a lot of patients. We cross cover way more than 56. And I imagine we probably get calls for high blood pressure, for sure more than 56 patients in a week at least. So
They haven't treated the pain.
exactly. So lots of reasons we get called on this and might treat and then could easily harm patients. And then if you use IV antihypertensives, the outcomes are even worse.
Even if it's a one-time dose?
Mhm. This was one of the studies I did at our SHM update, so I didn't want to pull in all the details because it's a lot, and also I couldn't get it to reformat. So I just went with the summary, but that study, they looked at any patient who had a blood pressure of a systolic greater than 140 in the first 48 hours who received any antihypertensive medicine other than their home meds. And the outcomes were pretty much worse across the board. So for asymptomatic patients, what you really want to do is just restart any home meds they had. If they didn't have home meds, you might want to start something if they've never been on anything. I would only do that if it's been a series of high blood pressures. An isolated one I really generally would not treat. And then the only other time is if they're undergoing a surgery or a procedure where having hypertension would be deleterious. It's not the word I wanted to use, so it came to mind. But
That's a good word.
oh, thank you. So that would be one other situation. So the extreme pressures, if you have no meds you could give because they're not on anything, you might want to start something, and then if they're having surgery, otherwise just restart their home meds. So then if you have to pick a new med, well, I guess which med should I get? First agent would be home meds. But then if you have to pick one, you would just use your standard hypertension guidelines. There's no real reason to do Hydral or Labetalol, especially the IV forms, just because they're here and easy. If they're asymptomatic, there is no rush to lower the blood pressure, other than avoiding calls from nursing. And then don't use IV unless you absolutely cannot give them PO or they have zero enteral access. It's really the only time to use IV for an asymptomatic patient. All right, so then a discharge. So for the most part, you just send them home whatever they came in on, unless they had hypotension or an acute kidney injury. And then if they were on an ACE inhibitor, a diuretic, then you might want to hold their meds till next follow-up. If it's AKI and it was getting a lot better or maybe even normalized, I generally have them hold it another couple of days after they go home and then restart. And then avoid starting new meds at discharge, with the exception of patients who are not on anything beforehand, or if they have another compelling indication like heart failure, AFib, where you really need them on something for that. All right, that was inpatient management. Now I'll talk about a couple of complications. Really, we're only gonna talk about one complication. I'm just gonna briefly summarize the others. So cardiac, you've got LVH, or sustained hypertension, heart failure, both forms. Ischemic heart disease, you can get ischemic stroke, intracerebral hemorrhage, all the microvascular disease that causes stroke, and then of course renal disease, and then hypertensive emergency. So first, urgency versus emergency. Many of us don't believe urgency exists. I'm one of them. So urgency has historically been defined as a systolic greater than 180 or a diastolic greater than 120, but without symptoms. So no end organ damage, no headache, etc. In most cases, you've got days to a week or so to lower the blood pressure. So there's no urgency. I think no true urgency. You just really usually just start them with some oral meds and have them come back to clinic. You would not typically have to admit a patient to support high pressure like that. The only exception to that would be a patient with a really high risk of an imminent event from that high pressure. So somebody who has a known aortic aneurysm already has like a type B dissection that's at risk of redissecting or worsening dissection. Those you want to do a lower it more like hours to days. But honestly, I feel like those almost fall into the emergency category personally, but they didn't. So then your emergency patients are the ones who have the high blood pressure plus some form of end organ damage, which we'll talk about here. So acute kidney injury, I feel like it's the most common one we get called on because usually the other ones have already gone somewhere else. Acute MI, acute heart failure, aortic dissection, acute hemorrhagic stroke, hypertensive encephalopathy, press plus minus. Press always has hypertension. It's not necessarily caused by hypertension. It can be.
Like 2 weeks ago here.
Yeah.
They were in the hallway. We had to take an emergency to ICU. She lost her like vision. She started having a fit.
Perfect place for that patient to have been. Lovely. And then preeclampsia or eclampsia, which I hope to never have to manage. All right, so how to assess them to figure out if they're having that, which hopefully the ER has done this. So headache, any neuro symptoms, weakness, seizures, confusion, vision changes. Do they have chest pain? Do they have severe acute back pain that makes you think they're dissecting? Are they short of breath because they have flash pulmonary edema? Are they nauseated and vomiting because their ICP is up? Are they pregnant and we don't want them near us? And then did they just snort a whole bunch of cocaine or take a whole bunch of amphetamines? Or insects for that matter. And then for your exam, you want to do a complete neuro exam, ideally a fundoscopic exam. Don't think the ER has ever done one of those. But in theory, one would like to have looked for papilledema or fresh flame hemorrhages, though I will say, I don't actually know how to tell if a flame hemorrhage is fresh or not. That's just what research says, but I can see, I know what papilledema looks like, so I'm gonna stick with that one, but. And the workup should get an EKG. You want a chest x-ray to look for pulmonary edema, a troponin, of course, renal function panel, or at least something with a creatinine. If you suspect they might be having a hemorrhage or hypertensive encephalopathy, you'd want a CT at least. And then if you think dissection, you want a CT with contrast. Management, it does vary by which organ has sustained damage, but these all require an IV drip. And all of them are best managed in the ICU. How to convince the ICU of that, I do not know, but they are all best managed in the ICU. Your overall BP goals, you want to decrease the MAP by about 10 to 20% in the first hour, but then you want to go slowly for the rest of that 24 hours, only 5 to 15. So max of 35%, really more ideally 25%. But you might overshoot that first hour and then end up closer to 35. The only exception is aortic dissection. Those you want to get down fast, all the way down to like 100 to 120 systolic and like really fast, like 30 minutes, because you don't want them to just completely shear their aorta in half. Medications, all of these are things we should not be giving, but I'm just going to mention them for the sake of doing it. So for AKI, it's actually phenoldipan, which I had forgotten existed. But it's a dopamine 1 receptor agonist. So unlike all or most of the other antihypertensives, it actually maintains kidney perfusion while reducing BP. Most of the other ones reduce, like ACEs and ARBs, for instance, reduce afferent not dilate. What's the opposite of dilate? Constrict. Thank you. They constrict the afferent arterioles in the kidney, and that helps reduce blood pressure, but unfortunately increases or decreases the blood flow to the kidneys. So the kidneys are more likely to get worse, but phenoldipan has the benefit of not doing that. MIs, nitroglycerins preferred, but you can do clobidipine, nicardipine, or even beta blockers. Heart failure, nitroprussides preferred, or nitroglycerin, and then you also want to give diuretics to diurese them. Dissection, you really want to give a beta blocker first, and then you give a dilator like nitroprusside or clobidipine. Stroke, they usually do labetalol or nicardipine. It's tricky with strokes because you're trying to balance. You don't want to constrict the brain vessels too much, because then you're going to make the areas that aren't stroking have more damage, but you also don't want to let too much more blood get to the hemorrhagic site. So it's a delicate dance, but those are the two that they generally will start with. And then hypertensive encephalopathy, clobidipine, nicardipine, or phenoldipan, and then preeclampsia, hydral or labetalol. And part of that's because they have to choose ones that are safer in pregnancy. Again, we shouldn't have to be doing any of these, but yeah. So in conclusion, take-home points. Resistant hypertension has to be 3 max dose meds, and one of them must be a diuretic. Think about secondary hypertension for anyone with resistant hypertension, hypertensive emergency, or a systolic above 200. First line are ACEs, ARBs, calcium channel blockers, and thiazide diuretics. You want to pick your agent based on patient's comorbidities when that applies. Avoid new antihypertensives in the hospital, and hypertensive emergencies should go to the ICU. But they don't, but they should. The end. Questions, comments, concerns?
I have a question. Yes. So when you have someone who, let's say they have a blood pressure, they're like, oh, 190, 200, they are having some chest pain or they have a headache. So they have like symptoms, correct?
Mhm.
So then you're like, okay, well, their home meds have already been restarted. You look at them, they're not in pain. Or like, and it's real, like we gotta treat it. So at that point, you're thinking something IV, correct?
So it depends on if you've exhausted all of your oral options. So like you restarted their home meds, but were they just on amlodipine at home? Then you could add
So you could
something
add
else.
something oral, even if they were having like really
So,
bad headache, or I'm having.
If it's
chest
a
pain.
really bad headache, then you do start to get into the worry of, is this becoming emergency?
Right.
In which case you need to kind of start that workup kind of over essentially. So you've done your history part already, but then you'd want to look at getting an EKG, troponins, potentially head CT, trying to figure out, is this truly end organ damage now, or do they just have a migraine because they didn't sleep? So it's hard, like headaches are really hard one in particular, because it's so many other hospitals.
They have chest pain, so I'm like, okay, I'm gonna get a troponin, that's gonna take an hour to get back. If I'm lucky, right? If you have like a spot nurse and he's like, gonna get in, be aggressive. My question is like, if you do, like, at what point then, when we're on the floor, like, and, when do we start thinking of IV, which IV med, like, are we gonna give IV, and then also which IV med would you start with? Which I know to a grain of salt, like, if they're like bradycardic or whatnot, they don't want to not, but in general, is there a systematic process that you use?
So I generally would still do oral in that circumstance, because if I'm doing IV, I should be doing a drip. Like if I truly think this has become a hypertensive emergency, an isolated IV dose may drop them too fast or too much. Oral could too, to some extent, but oral is generally going to have a lesser effect, at least acutely. So I would still pick an oral. If I really think they've progressed to a genuine hypertensive emergency, then I'd be calling the ICU and saying, I really think this person needs a drip.
So you basically like no IV.
Unless they just have zero enteral access. That's my personal opinion. Others may differ, but the data has shown us that it does not benefit. It only can cause harm. So the only rule or the only reason to use IV like single doses, in my opinion, is if you just have no way to give them an oral med. Doesn't mean the rest of the world will stop doing it.
Sure.
My personal opinion.
So you were just, would you max them out, obviously more on the agents they have rather than starting?
Yeah, I mean, I might start it like if they're on pretty hefty doses of everything, I might try an additional agent rather than increasing it. Like if the difference between like 40 and 80 of lisinopril is not a huge jump in terms of blood pressure decrease. So I maybe would switch to adding an additional agent at that point. But if they're on like, what is it, what's the lowest pyridoxal one? Is it 1 point? Yeah, thank you. I knew there was a 1 in there, but I had it in the wrong place. If you're on like that, then I would definitely escalate that before picking a different agent. That's
So just kind of depends on where you are in the dosing.
Yeah. It's all gray area, a lot of it, like picking, like whether to go up on a dose or pick a different agent. I do think going up on an existing agent when you are low enough in the dose is probably preferred because they've already got some in their system, so you might get more benefit. They're not building from a level of 0 to try to get to steady state. They're at a low level steady state. You're giving them an extra boost. But there are still certainly circumstances where you just have to add a new med.
And